In the next 10 minutes, I'd like to give a general approach for recurrent pericarditis from clinical trials to clinical practice. And you can see here on this slide, you have the imaging, you have the therapeutics, and you even have surgery. These are my disclosures. So I'd like to give a general introduction, talk about some of the clinical syndromes for pericardial disease, what's the role of multimodality, show some quick cases, and an imaging-guided approach. You know when you made it big when you go on TV, so I was very fortunate in the last few years to be on PBS, MSNBC. I even made a cameo on Netflix, Open Heart, with the hockey player Lundqvist. And I had a nice shout-out from Don Staley on ESPN around a year ago. So you know you made it big when you go this. And a little bit more about Don Staley later. But it all started with the Rhapsody trial back in 2021, where we published IL-1 trap, rilonacept, and recurrent pericarditis. And more recently in JAHA, what happens long-term with rilonacept. Craig mentioned our international consensus paper from 22 experts all around the world. This is, we're still waiting for an ACC guideline. However, in this consensus paper, we discuss recurrent pericarditis, pericardial effusion, constriction, pericardial masses, and we came up with some algorithms and a little bit more later about the consensus paper. When we look at pericarditis, you have to decide where you are on the spectrum, whether you have ongoing inflammation, what disease you have, acute or recurrent pericarditis or burnt out, and what type of constriction do you have, constrictive physiology? Is it transient, subacute, chronic, or calcific? And the imaging plays a major role when it's actively inflamed or burnt out. So here's an imaging biomarker. Here's an MRI. And you could tell a lot from this one picture. You could see edema around the heart, and you can see inflammation. From this one picture, you could predict this is going to take 3 to 5 years to heal, to get off all the medicines, likelihood of going on a biologic. So this is very, very powerful. And this was a 17-year-old boy with recurrent pericarditis. So there's some debate. You need to do imaging prior to the biologics, and I think very important that we have a good baseline so we know what the prediction is. In pericardial disease, there's many syndromes. So these are the choices. Acute and recurrent pericarditis. Here's effusion tamponade, constriction, effusive constriction. See the septal bounce. Here's lymphoma, pericardial masses, and congenital absence of the pericardium. When we look at pericardial disease, we want to look at the pathogenesis. So we mentioned some of the syndromes, but you have to look at the etiology. What is the trigger? Is there inflammation? Is there autoinflammation or autoimmunity? And what are the genetics? All coming into that signal to give those different syndromes. Who comes to Weston in Florida or Cleveland Clinic North? Patients that have most acute pericarditis will resolve, 80% will resolve, but there'll be a handful that get complicated. A third will get recurrent, 6% multiple recurrences, and then there'll be a few percent that have this constriction, this inflammatory constriction, and a few end up calcific. Back to Dawn Staley, our prototypical patient. So she had picked up a virus at the Rio Olympics and had recurrent pericarditis and came to see us and wasn't a biologic, it's all public knowledge, and has got better. In the U.S., the most common cause would be you pick up a flu. Now, I have a little bit of a cold, but I'm getting better, but hopefully I don't get pericarditis, but that would be the most common. If you live in India, it'll be tuberculosis. But more importantly is, I always pick on Dr. Kanj, but post-cardiac injury, when you have an ablation gone bad, we heard a lot about, you have to be in sinus rhythm, but more and more procedures, PCIs, open heart surgery, can cause recurrent pericarditis. We shouldn't forget about autoimmune like lupus or neoplastic disease. There are different stages of pericarditis. Who thought it was so complicated? But you have acute or first recurrence, multiple recurrences, you have colchicine resistant, steroid dependent, and you have constriction. And then you have choices of when to do the echo, for example, looking for a fusion, when do you do an MRI, when do you do a CT. And then you have the different therapies, NSAID and colchicine for weeks to a few months, and weeks to 6 months, and then when do you add prednisone, and when do you do steroid sparing, and when do you do pericardiectomy. Imaging, we had a lot about this conference about multimodality imaging, and we'll hear more about that, but echo is always first line, followed by MRI or CT, or even PET-CT. This is important for diagnosis, prognosis, and surveillance. So it has a major role in a so-called imaging-guided approach of pericardial diseases. Here's an example, 3 examples of an MRI showing the interventricular dependence, calcium around the heart, somebody with TB, and here anterolaterally, it looks a little pink. This is what you call strain reversus, or the hot septum that you see in the constrictive pericarditis. How do you treat pericarditis? Well, this is the ESC guidelines. I should mention that there will be new guidelines in this summer in Madrid, Spain. But traditionally, with acute and recurrent, very similar drugs, aspirin, NSAID, colchicine. Recurrent, it's same drugs but longer. The biggest cause of recurrent pericarditis is undertreatment of the acute. If you have somebody that has acute pericarditis and they're given just roughly a week of medicine and they stop it, it'll just come back. There's a stepwise approach from the Europeans. And I should mention this is what's current in 2015. This is obsolete now, but I'll just go through this for the sake of time. So first line is NSAID colchicine plus exercise restriction. The biggest fight in the office is about exercise restriction for these patients. Often second line would be low-dose steroids. For recurrent, third line would be things like biologics, and fourth line would be pericardiectomy. And as I'll mention very shortly, there's a paradigm shift trying to avoid the steroids in these people. In terms of the pathophysiology, it's a very busy slide, but let me take you through this. So I'll pick on a PCI. So you perforate. When you do your PCI, you get damage to your pericardial cell. The injured pericardial cell will release IL-1 alpha. Macrophages will be attracted. There will be activation of the NLRP3 inflammasome, and they'll convert from basically a proform to an active form, IL-1 beta, the alpha and beta attached to capillaries, and you get this inflammation. Here's another example where the drugs may work, anakinra, which is basically a receptor antagonist. Rilonacept traps IL-1 alpha and beta, and canakinumab also as an IL-1 beta trap. Colchicine affects the inflammasome, and there are some newer molecules out there from different companies, Cardiology Therapeutics, Ventex, that inhibit the inflammasome. Trials are quite limited. There's anakinra, the AirTrip trial, and this showed that anakinra in 21 patients decreased the number of recurrences. Roughly with anakinra, it was 18% versus 97% recurrence, 90% recurrence with placebo. Rilonacept was very important in the Rhapsody trial, showing lowering the risk of recurrence quite dramatically compared to placebo, 96% risk reduction. However, with the long-term extension, after 18 months, patients who stopped it, there was such a high recurrence rate, 75% recur versus only 3% that stay on it. So it's a long-term disease. Here's a quick case of a steroid-dependent patient was put on prednisone. Here's his phenotype. You can see there's a septal bounce. There's inflammation. MRI baseline very severe. Follow-up was good. However, he did 2 years of rilonacept, and unfortunately, when he stopped it, it did come back. So 12 weeks recurred after stopping rilonacept, and he's back on rilonacept. And we're trying to figure out whether we have to just stop it, wean it. These are some of the possibilities. This is from the Resonance Registry, published in ESC 2024, showing in purple the increased use of biologics, whether anakinra or rilonacept. So it's really changed the practice. The drug has been approved from 2021. I should mention another drug called cannabidiol, CBD. We were going to call this the happy trial, but not so happy. But it's basically a pharmaceutically grade hemp that seems to be, in pilot studies, showed lowering CRP and chest pain. So there'll be another trial called Maverick 2. If that doesn't work, we send them to surgery. Here's a pericardiectomy in one of our patients. And we do a couple a month of pericardiectomy for recurrent pericarditis. Using machine learning, Dr. Sengupta done a lot with machine learning, but we came up with different risk scores. For example, things that we figured out, a faster heart rate is not so good. LG is obviously a bad thing. Autoimmune is a bad thing. And then you could add this up and come up to a high-risk score, or a low-risk score, a moderate risk score. And guess what this risk score is called? Decline risk score. So I guess I'm like the Chad's VASC. There's a decline risk score, and we're trying to test these risk scores in pericarditis. And finally, the take-home message basically is if you have somebody with recurrent pericarditis and you're failing the standard, if you do respond, that's good. You can taper your medicine. If you don't respond, is there inflammation? If there's active inflammation, therefore you want to add I1 agent ahead of steroids. If there's no auto-inflammation, you're not sure what to do, you could consider low-dose steroids or even an I1 agent. If that doesn't work, consider pericardiectomy. There are some clinical trials, very briefly. There's the Maverick 2, which is oral cardio phase 2 double-blind study, targeting patients that can't come off the biologics, so they're targeting that group. Ventex is a startup company doing a phase 2A open-label pilot study of oral VTX2735, which is an oral agent that affects the NLRP3. And another agent that just came out, KPL-387, which will be a phase 2/3 once a month agent in recurrent pericarditis. So in summary, I think we have this covered from imaging. Now we have the therapeutics. We have long-term therapeutics, and it's time to change the paradigm shift. And finally, it takes a village. This is our group at Cleveland Clinic, a strong group for pericardial disease. And finally, I should thank some of my colleagues and patients, but here's Dawn Staley back visiting us in Cleveland. Here she is at NBC Studios doing an interview with me, and here's her winning the championship in Cleveland last April. Thank you so very much.